Okay, I think we are live now. Oh no.
What?
I don't think it's gonna go on my Instagram.
Why?
You know how Instagram's kind of finicky? If you click away from the center box, you sort of lose that live video encounter.
No, I don't, but I think I'm live.
Here's...
Do you want to restart everything or no?
No, it's okay. Yeah. I've been probably negligent enough on my Instagram account recently anyway. So
Oh,
I'm
boy.
getting better. I'm trying to get better at it. Yeah.
But I guess we're on YouTube probably. And
Yeah.
okay. All right.
All right.
All right.
Hello, everyone. We are live.
Yeah.
Thank you all for tuning in. And I'm Dr. Brandon VanderWel.
Dr. Tan, hello.
Welcome. And today we're going to talk about a weight loss options. And Dr. Tan, I understand we already have some pre-submitted questions.
Well, actually, I think we're on a Viva's live. Okay, anyways, I'm getting distracted. I think you are live, but it's on the Viva Insta. Anyways.
Oh, really?
I don't know. I think
well, if I don't see
our age is showing, we're like,
if I don't see a comment in the comment section, I'm sorry.
Yeah, I'm sorry too. All right. So I figured it's been a couple weeks since we did our last live seminar. I thought a cool topic to talk about, which is probably like one of the bigger questions that I get from folks is like, how do I choose the right weight loss tool for me personally, right? Because now there are thankfully like more and more tools for us to choose from, and more choices is always better, but then it does get a little bit more confusing to pick which approach to go through. It's kind of like that Amazon effect, you know. It took me like a year to buy a vacuum because I couldn't
too many choices.
Like,
too many choices.
Choices. It's good and bad. So, well, I guess we can start with, what is your general approach for choosing the right weight loss tool for? Well, let's start with, what are the weight loss tools that we have available to us? You know, which I can go over. I'll just go over them really quickly. Like the first one that we have is probably like the kind of tried, maybe not so true one, which is lifestyle changes, right? Which is a valid tool.
Tried again.
Tried. But lifestyle changes, it's definitely still worth talking about. It's still really important, but essentially eating less, exercising a little bit more. But that's the first tool in our toolkit. The next tool now that we have is going to be these medications, which we've also had for a long time, but now we're getting newer medications that are more effective. And so that's been a huge topic of conversation just on social media and the news, in our office, obviously.
In shareholders' letters. Yeah.
Commercials.
I guess Eli Lilly's stock plunged like 10% this week because they missed their goals for mostly like Mounjaro. Yeah.
Oh.
And by missed their goals, it means that they only made $3.1 billion in the quarter three, as opposed to 3.6. Yeah.
Wow. That
was just Mounjaro, not even Zepbound. Yeah.
Just an unfathomable amount of money, one way or the other, to me. I was going to bring up some much less highbrow news, I guess. Lizzo dressed up as Ozempic for Halloween. I don't know. Just thought that was interesting.
That's probably going to make the shareholders letter, actually.
Let's see here. Other things. And then, so the last tool, though, for us, just to put us back on topic, is surgery. All right. And surgery also is now kind of a little bit interesting over the last few years, because now we have more surgical options, and we have surgeries that are not really surgeries anymore. We have like procedures that are kind of in that category too.
Non-surgery sleeve, endo sleeve.
Yeah, I call it the incisionless sleeve.
I don't like that.
I don't know. And so certainly a lot for us to kind of parse through, but
yes.
Maybe if you can start with, how do you approach the conversation of like picking which tool is best for patients?
Yeah. I'm going to start the conversation, start my cat thing with a caveat, which is I'd say this is my approach now, and we're getting more data on this, but we don't have like decades of data like we have been operating with in the past. But I would say it's always customized, right, to what the patient is, like where they're starting from, which of course sounds like a cop out. But I mean, if you're BMI 32, like 30 or below, and you want 32 or below, let's say, and you want the best procedure with the least amount of invasive, best procedure with the best amount of weight loss, then probably a laparoscopic sleeve plus or minus some medication afterwards.
Mm-hmm.
If you are in the low BMI or like BMI below 30 and you're like, yeah, I'm still like 50, 60, maybe 50 pounds above my historic adult weight, maybe even 40 pounds, really like doing what I've kind of termed the celebrity protocol, which is endoscopic sleeve and a GLP-1 is a really nice option for a really good amount of people there. If you're in the BMI 30 to 50 category, generally the laparoscopic surgeries work best. And I think the laparoscopic surgeries with a medication afterwards for about a year, same way we do with cancer. Get a surgery, you get chemotherapy for a year. Bariatric surgery, I think the long-term data is really going to be the best for the most amount of people if we do a procedure and we do medication for a year afterwards.
Mm-hmm.
And we've been doing that now for a while, and cool stuff. Yeah, really, really cool stuff. So
yeah.
And that's where I think also like the endoscopic sleeve really shines when in conjunction with the GLP-1, and they work really well nicely together because the endoscopic sleeve really makes your stomach smaller, makes you eat less food. It does have a bunch of the hormonal benefits, and then you get really hit hard at the hormonal benefit part with the medication. And you also don't need as much medication. Like you need noticeably less medication with an endoscopic sleeve than if you have a normal stomach. And together, those two really help people make some great amount of progress, really lock in some things in their life, and get more weight loss. And I think maintain that weight loss longer because their stomach is also modified, even if they come off the drug. And I think that should be, for the tens of like 100 million people are in the category of, BMI 30 to 35. And I really think a very, very, very big portion of them should seriously consider the endoscopic sleeve with GLP-1. But I think the laparoscopic sleeve, if you're willing to do it, is a great tool. If you're willing to add medication to it, even better. And if you're BMI 50 plus, then, I think I tell people like, the endoscopic sleeve may not be a big enough tool for you, may not be a big enough gun, but I've still seen people do really awesome with it. But the laparoscopic surgeries are like, much more tried and true. And then plus the medication is fantastic. So
yeah.
Your thoughts?
Yeah. I think there's a couple of points that you made that I think are really good. And the common theme is that like weight and obesity, etc., we should be looking at it more like a chronic disease. It is a chronic disease, and we have to be addressing it like any other chronic disease. And for a long time, the first tool in our toolkit, diet and exercise, that's been the advice that we've been giving people for so long. And that's not acceptable medical advice for pretty much any other chronic disease. So I don't think we should be using it as acceptable medical advice across the board for folks anymore either. It's probably reasonable if you're trying to lose like less than 5% of your total body weight, right? So like if you weigh 200 pounds and you want to lose 10 pounds, then fine. That's probably a reasonable first approach there. But for most folks who have excess weight and are feeling the detrimental effects of that excess weight, whether that's prediabetes, hypertension, anything, or just having your joints hurt more than you want them to, you can't get around as easily as you used to be able to, you probably want to be losing more than that 5% number. And you're going to be far less likely to be successful with just diet and exercise alone, because your body just wants to hold on to that weight for various reasons. And so that's where these stronger tools are going to come in. And then that's kind of where I think things are kind of fun, because then we kind of can figure out what works best for you personally and your goals. I think in medicine and probably in most patients as well, they want the least invasive, safest option that they can get a hold of. And I think naturally we think that medications make the most sense in that sense. I think the missing part of that picture is that a lot of these surgeries are some of the safest surgeries that we do. And there are the benefits of surgery sometimes really outweigh some of those downsides that we will encounter potentially with surgery, in that it is going to be a little bit more effective and it is going to be a more durable tool, essentially, for a lot of folks.
It's also more cost effective.
It can, yes, and it absolutely can be more cost effective as well. And so for all of those reasons, surgery should be in the discussion for a lot of folks, and needs to be in the discussion. And I will also say, I think the other thing to highlight though is that, again, for a lot of folks, you probably need both. Actually you need all three tools, right? You need surgery, you need lifestyle changes, and you need medications. And I think the cancer analogy, I always wonder if cancer doctors are like rolling their eyes hearing stuff like this, but I think it's a perfect analogy, in that cancer is something that you have to throw all your guns at, right? To fight it. And obesity is such a complicated disease. There's so many like facets to it. It makes sense that you also have to throw a lot of your tools at it in order for us to effectively address it. And so a lot of folks, one tool is not going to be enough. It is going to require multiple tools. But the other nice thing is though, that like, I think the order maybe doesn't matter so much of how we approach things, you know. You can do medications first and then go to surgery. You can do surgery and then also add on medications. There's a lot of different kind of ways to go about it. And I also think like BMI though, like it's always hard setting a hard BMI number, right? For our patients, because one BMI for one person is going to feel very different for another BMI for another person.
For sure.
And so we can, we throw out numbers, but at the same time,
they're crude and it's crude.
So personalized, right? Yeah.
What do you, what do you think people should do if they're like, where should I start? Should I start with medication and see how it goes? If, let's say I'm a BMI 40 plus, should you start with medication and just like, hey, let's see how it goes? Or, where you usually kind of say that line is where you should, like, where do you need to seriously consider surgery? Or a procedure.
Yeah. I think this is where like the numbers are very important for our patients to know, or kind of like roughly how much weight loss they can expect with each of these tools, right? Because it is like choose your own journey in a lot of ways.
It really is.
How do we want to go about this? But I don't want you to come out a year later and be disappointed with what we've accomplished in that year. And so, with these medications, and I'm mostly talking about, well, I guess we can go into the medications a little bit in terms of like the specifics. The oral medications we've had around for a long time. And my experience with the oral medications is they're a little hit or miss, I would say. Like oftentimes people don't respond to them. And then the people who do respond to them do really well with them. But we're probably looking at less than 10% total body weight loss with a lot of these oral medications. The injection medications are the newer ones, and these guys are a lot more effective. More people respond to them as well, which is, I think, really nice. But weight loss wise, if we look at the big papers, we're looking at 15 and 20% for the two most popular medications. But, we've talked about this a lot. It's like, that is very ideal settings for folks. There's a lot of reasons why people might stop taking these medications, whether that's it's too expensive, they can't get a hold of them, they have side effects, lots of different reasons. But if you stay on these medications and really try to stay on these medications, that's probably average what we're expecting to lose.
Maybe.
So again, if you weigh
Maybe.
200 pounds, yeah, maybe like 30, you know, we're looking at, oh, I hope I'm doing my math right now, like 30 to 40 pounds on average. But again, in real life settings, there's a lot of reasons why people might lose less than that 15 to 20%. And so real life numbers are probably a little bit on the lower side. I'm often quoting that 15 to 20% with my patients, but I sometimes wonder if I'm overestimating a little bit some of that weight loss. But anyways, you know, I give those kind of rough estimate numbers to patients. And I'm like, if you're going to be potentially happy with that type of weight loss, then great. I think, you know, medications are a great way for us to start. But realistically, for some of our patients with higher weights, they want to lose more weight than that.
What about maintenance?
What do you mean by maintenance? Oh,
after they lose the weight, then what?
Yeah, I mean, that's the other big question that people will ask is like, do I have to stay on this for the rest of my life? And I think this is, again, one of those things where like obesity is a chronic disease, just like hypertension or diabetes. And same with hypertension. If you have high blood pressure, you start a medication and you stop that medication, you're very likely, you know, your blood pressure is probably going to go up again. The weight loss piece is a little different because ideally, right, you're changing some of your lifestyle along with the medications during that process. And
It's
if you
also
maintain,
a behavioral disease. Yeah.
Exactly. So
it's
if
biological
you maintain,
and behavioral. And I think when people don't acknowledge that it's behavioral and biological, like you need both. You need to understand both of those. Yeah.
Yes. Yeah. And so if you're able to adjust the behavioral pieces and the lifestyle pieces with those medications and maintain some of that once you come off the medication, then yeah, you'll likely maintain a lot of maintain your weight loss. Right.
But these drugs work for a reason.
Yes, and like the data shows,
for a
like what the
reason.
data shows us is that most folks are going to regain weight if they stop. And so we do also have to, I don't want to give people false hope in that we can get you off these medications once you reach your goal weight. We try, you know.
That's where it is an interesting calculus of like, do you maintain, do you do, because I mean, a lot of studies I've seen is like, you know, 30 to at best 40% maintain their weight loss, you know, after the medication, they stop it. And hopefully that number gets better as we get better at using this medication. But like 30 to 40%, it's like, I mean, we're just talking about like that's not even as good as the band, you know?
Yeah. And 40% high. I don't know if I've heard that. That's a high number. Yeah, that's a.
I was just being generous because the stuff I see, like the highest I see is 30, but I was like, maybe there's a 40 out there.
Yeah.
Maybe. But I will say, I think I say 40 because the studies that I read have been cold turkey stops, not wean off.
Right.
And I think a wean down will help people adapt better than a sudden withdrawal.
Yes, I agree.
Because these meds work for a reason, is because they have powerful hormonal effects, and they are at 5, 7, 8x what your normal hormone levels are of these medications, of these hormones. And so they do that anytime you hit a hormone, an important one is particularly with that much, you do have side effects, or there'll be side effects for many people, but also it does a lot of stuff. And if you take that away, you're exposed. Like it makes it so much harder. So that's why these things, it's not like a trick that you take these medications and you're tricking yourself into eating less food and feeling less hungry. It's like they are literally doing that. And
physical change, I know.
It's really hard to trick yourself into feeling like you have the medication back. So that's where like working in combination with the drug and the medications, with the surgery and the medications, I think is really going to be where the sweet spot, the data is going to show the sweet spot lands long-term wise. So, yep. Martavius 144 says withdrawals confirmed. Yes. Yeah, no, it's a real thing. Like you can't find your drug at the pharmacy, you can't find it or whatever. And you're just like, dang, this is hard. And it's because these things work for a reason. They work.
Oh.
They're making. I got Eli Lilly's stock report here. It's like $3.1 billion for Mounjaro and 1 point something billion for Zepbound in Q3. Like, it's because these things have a powerful, profound effect on biology. And food, the drive for food is so primal, and the drive for food is so strong, and it consumes so much of your thought in your life. When you can just chill that out, man, it feels very freeing for people. And I mean, that's why you have, 1 in 8 million Americans have tried this. So,
Mm-hmm. Yeah. Yeah. So
along that lines, the other question we had was, when is surgery versus medication the best tool for weight loss? I think that sort of is a good question, maybe segue into that then.
yeah. So when is surgery? Yeah, I think we touched on I think different doctors and different surgeons approach this differently, but I'm pretty much like whatever you feel the most comfortable with right now, like what you're ready for right now is how we should go about this, right? For
Do
some
you say
folks,
that for the window, do you lean conservative or do you lean aggressive?
what do you mean for the window?
So people have a window of like, I could just try medication, or maybe I'll consider an endoscopic sleeve, or I could do medication, or maybe I'll consider a laparoscopic sleeve, or maybe I'll do a laparoscopic sleeve, but I would also consider a gastric bypass. Like, what do you usually recommend? Do you say go with the least conservative or go with the most aggressive?
I think you go with the most aggressive that someone is willing to kind of do, right? Because the more aggressive, generally speaking, actually globally speaking, you're going to lose more weight with it.
Globally
right?
speaking, yeah.
Yeah. The more aggressive we are, the more weight that you're going to lose. Unless you're like, it's an unhealthy amount of weight or something that you want to lose.
I think the most
We're
aggressive that we're
realistic.
willing to offer. Yeah.
Exactly. So I think I match my patients with where they're at. And some people they're willing to jump for the lap sleeve. And I'm like, okay. And this is how much weight we think you can lose with the lap sleeve. Is that going to be healthy for you? If it's a yes, then we go for it. But again, some people are not ready for the lap sleeve. They're ready for the endo sleeve. They're ready for meds, whatever it is. You kind of meet folks where they're at. But I think another really just important part of when we first meet our patients is there is so much misunderstanding about these different the pros and cons of each of these tools. And so oftentimes we'll spend some time just kind of going through what are the pros and cons. Does that actually fit within what you want in this tool that you're trying to pick? And so I'll have the way our clinic works is we have either visits that are medical weight loss directed or surgical weight loss kind of directed. And sometimes we start out thinking we're going to want meds and we end up with surgery because it ends up being a better option for someone. And so it's a little bit of a discovery process with each person, I would say. Yeah. How about you?
We collect data in an intentional fashion. We'll have, how when we were studying for our surgery boards, you just print off all the NCCN guidelines. That's the National Cancer Guidelines. And it's a very clear algorithm. You have stage, you stage the cancer, and you have this stage, and then your recommended flows are this, or this. And you go through and you follow these algorithms. And I think that's the dream, is that we have very good data to support a scientific approach to people's stage of obesity. Like, we stage their disease, and then we give them all the behavioral treatments, the surgical treatments, and the medication treatments.
Yeah.
And I think we'll finally start making some progress on this thing. What I think is going to be really exciting is that. So I just recently heard that in 2023 was the first year that obesity went down in the United States. It was the first year that it didn't go up. Yeah.
I need to spend some time looking at that data because I'm a little. I think there's a clear guess as to why that's happening, but it
was it went from 40.3 to 40.1%. And my guess, which is it's still not good, or it was 42.3, I think, to 42.1, something like that. But I would guess that's actually pretty true because the junk food share prices have really taken a hit since the GLP-1s have come on the market.
Look at you just looking at the stock numbers.
Well, like, this is the thing, like science, like surgeons, doctors, we know science pretty well. We know these other things, but like our bigger context things, like just look at where we're at in the global world of, of everything. Like the medical device companies that support bariatric surgery, their market cap's not even $1 billion. And the miss on guidance of the miss percentage of 17, 18% or whatever that was for Mounjaro is more than the market share of the entire medical device industry that supports bariatric surgery.
Crazy.
Like it's just important to put these things into context and like understand what these things are. And what I think is, I think it's fascinating too. Behavioral psychology is the most fascinating. It's such a fascinating thing that drives so many things, right? And you just see the Overton window. Do you know what you're familiar with the Overton window is?
No, I'm not.
So the Overton window is a principle of there is certain things that are acceptable to talk about in a certain way for society and how that shifts throughout history, right? So like a great example, some politically correct ones are like talking about like segregation, how like classically segregation, how you talked about race, how that Overton window keeps shifting towards, being much more egalitarian and, being more accepting about lots of different things in regard to race and ethnicity stuff. And then, and the Overton window from an obesity standpoint, right, has always been like, I mean, bariatric surgery has never broken into the Overton window. Bariatric surgery is not part of the normal lexicon.
Yeah, less than 1% of the people who need
less than 0.1% of the people that should get bariatric surgery get it. But even then, like people your average person on the street knows almost nothing about weight loss surgery. They don't even really know what it is, except for my 600-pound life or my 1,000-pound sisters. Like that's maybe as much as they know, if that even. Whereas now it's almost like the Overton window has shifted so rapidly with Ozempic, and now Mounjaro. The people that are like, oh my gosh, you take a pill for obesity are almost starting to be on the outside looking in, where it's almost like, well, if you struggle with your weight, like just get on these shots. Like, what's the problem here? Like, it's interesting to see how this is shifting in the global, in the big picture right now in the world and in the United States, that it's almost like, this is a treatable problem. Like, why are you still obese? Like, just get on these medications, like get your act together, get these things going. And the people that, a lot of people that come to us are like, well, I kind of don't really have any excuses now because there's just a shot, whatever it is. And it'll be really interesting to see how bariatric surgery kind of breaks into the Overton window. So.
Well, I think that's what's so wonderful about, I think that shift is finally, we as healthcare providers have something to offer.
A clear and obvious example of how obesity is a disease of biology.
Exactly. Where it is not a willpower issue.
I do think we hurt our credibility when we completely deny the behavioral component part of them. I think you have to hold both of those in your hand that, hey, this is a behavioral disease and it's a biologic disease, like obesity, like diabetes, really. Like you have to treat diabetes the best. You need the behavioral component, but you also need the biologic addressing because it is a disease. Yeah. It's a disease.
And I think like a nice parallel that, has recently seen a similar shift is like mental health, right?
Yeah.
We know that mental health, there are like chemical imbalances sometimes that people have that need to be addressed with medications. But at the same time, sometimes medications are not a replacement for behavioral therapy, like kind of working through some issues and lifestyle.
Sunshine, exercise.
Like there's a lot of things
Sleep.
that you have to change yourself too. And so
that's where I think there's so many a behavioral element to so many diseases. Not necessarily a behavioral treatment once you have the disease for a lot of things, like gallbladder disease. Like if you have really bad, cholelithiasis.
Take that sucker out.
Cholecystitis. You're not going to fix that one with your lifestyle modification. That's just going to suck.
Oh, you could just not eat fat for the rest of your life.
But even then, man, you're going to have some problems for a while. Yeah. So, appendicitis, you're not fixing that one with behavioral modification. So
Probably not.
That's not true. That's not a behavioral disease. So, but yeah, I got a question from Robert here.
Huh?
Do you think the post-COVID return to work could have affected the drop in obesity numbers? Maybe going back to school, office, so less snacking at home. It's possible. That's a good question, Robert. I would say, I don't know. I think I would kind of doubt it because we didn't see a huge bump in obesity with COVID. And at least from the preliminary data that we have currently, and also the trajectory before when people were not at home was still on the same pace. So my guess is that it's most likely that, I mean, there's 8 million people on a GLP-1, on a retail GLP-1, let alone, and there's another 7-8 million on a compounded GLP-1. So, I mean, if those people are experiencing, what the big data bases say, so like Providence's paper that they put out, 8% with semaglutide and 15% with tirzepatide. If you move that on, in their study, I think it was like 20,000 people, 20,000 patients.
There's a lot.
Yeah. Tens of thousands of patients, right, are seeing 8 to 15% total body weight loss. Like, you're finally going to start moving the needle. So that's just from a number standpoint, but yeah, interesting.
Definitely it's interesting times in general. I would say.
Very interesting times. 2025 is going to be a very interesting time with these medications. So,
Heather Grace Garrett says maybe I should invest. Let's be clear, we are not financial advisors. I don't know if I can speak to you, Brandon, but I cannot. I do not listen to any financial advice.
Yeah.
She also says that on the low dose, I can already feel some freeness of food noise. And that's one of the coolest things to hear, right? After starting these medications, it's just like, I didn't know I could feel this way. Right.
Yep. It's powerful. It's powerful. You can't deny that. And after people have been on it or they've seen people on it, it's like, wow, it's cool what these things can do. Yeah. I think just the danger is that we get siloed in tunnel vision there and be like, hey, this is the only thing that we should do. Where, we both have lots of patients that have been on a GLP-1, get surgery, still on GLP-1 afterwards. And they just say, like, universally, they're just like, man, it just works so nicely together. They work so nicely together. And they can be on a lot less medication generally afterwards. Which I think is going to be, we talked about what the numbers were from what are going through there with the amount of money that's going to change hands with these things. Having that many X's behind a hormone, as far as, 8X of a hormone is like, what's the other stream? What's the other downstream effects of that? We don't know. I don't think we really know yet. So it'll be interesting to see. I think we want to really keep our eyes out, but man, it's just fantastic to have more tools. We need more tools. Obesity is such a hard disease. It robs people of so much good life and health and longevity that we should be reasonable, but aggressive.
Yeah, for sure. Reasonable, but aggressive. I like it. Let's see here. What else should we talk about? What was that?
Oh, we had another question that said, how do you choose the best surgery for your patient? And I think it's just all these things we were talking about. It's what I like to do is, like, I'm not here to, like, my goal is to lay it out as many options as you want to talk about and give you the pluses and minuses of them and answer your questions to the best that I can. And we'll, whatever we can do to help you on this journey, we're here. But whatever's going to be best for you, really. But I encourage people, to do the most aggressive one that you're willing to do.
Yeah. I think that's true as well. And like, when you're picking at least a surgery, I would say there are some like medical reasons why I might push you towards one surgery versus the other, but probably most patients are good candidates for all of the above type surgeries. And so again, it's oftentimes just a matter of us talking through the pros and cons and picking out what makes the most sense for you. Unfortunately, there's no perfect surgery. There's no perfect medication. There's no perfect tool. And so it's really just a matter of, again, picking what makes the most sense. Do you have?
I was just thinking, in regards to like what to choose. Thinking about if you have diabetes, like frame the conversation in this way, which is if you have diabetes, right? Versus like if you have like a cancer, that's say, hey, we could suppress this cancer with medication and we could control it, but not really make it go away completely. Versus, hey, we can give you our really good shot of no longer having this or having way better control over it. If you have diabetes, like you should really be as aggressive as you possibly can.
Yes. Yeah. And I think that is kind of one of the caveats I would say to all of these conversations is that if you have diabetes and you also have excess weight, which is most folks with diabetes these days, in some ways we're biased because we're bariatric surgeons, but most people also don't know that bariatric surgery is probably the only thing that can potentially cure your diabetes. There's no medication that cures diabetes right now, as far as we know. And so if you frame it that way, I think that shifts how we look at these things a little bit as well. Does it cure it all the time? No, absolutely not. But it gives you a better chance than other things. And so that is, I think that I always tell folks, this is my soapbox, diabetes and bariatric surgery, but I think that's a much needed shift in how we address our medical care these days. They're starting to look at things that way in Europe. And hopefully that kind of comes to us soon at some point. What's your approach for picking medications for patients? Are you just mostly doing the GLP-1s now when you can and it's an option?
I kind of do.
Yeah.
I mean, I will talk. Most people come to me like, hey, this is what I want.
Yeah.
And it's sort of the same principle of like being the most aggressive of what people are willing to do. And especially since, the medications overall we see are very, safe and effective. And it's like, yeah, let's do this. If people have concern, I'll say like, hey, we can talk about the other, the almost legacy oral medical weight loss medications like phentermine, topiramate, some naltrexone, maybe a little metformin kind of considered in there. Bunch of other ones that you can try, but I generally like the data is just not super strong with those medications, and you're really hoping to shoot the moon really for most of these people to really get where they want. It can be helpful for you to take the edge off or something, or especially if you can't tolerate a GLP-1 or you shouldn't be on a GLP-1 for any number of reasons. Or you're just like, hey, I want to try these other ones first because they're cheaper and they're more accessible, and kind of have my concerns about these other things. Also, I think people that have some either ADD or they have some depression or
you're treating multiple things.
I think those ones like an upper, like a stimulant, appetite suppressant, can have multiple benefits there. So, and it may be good to have in conjunction with a GLP-1 even. So.
So, I have Marie Crow, who I think you did a sleeve on. She said the lap sleeve was the best decision I ever made. Thanks, Dr. V.
Oh, absolutely. Thank you for your comment. So, yeah, no, it's a great tool, but as like you're the one that has a tool and you use it well, and when you use that tool well, it can do some really cool stuff, and it's a journey, and everyone's on a little bit different part of their journey. But I think that's what's the coolest thing about this job that we have is the patients and just the seeing what a great, it's just such an honor to be part of that impact. So
yeah, I tell most of my patients that I have the much easier job of doing your surgery, and then my patients have the much harder job of kind of using their tool.
Change is hard. It's hard to change, but you come to a point in your life and you're like, I got to change. Things have to change. And I'm ready. So there's a great question is like, when do you think someone's ready for weight loss surgery and when are they not?
I think it is never so I think I
Maybe
haven't actually.
this is a loaded question because I think about this thing all the time.
It is, and I think what we know is it takes most folks years
Yeah.
to actually go from like knowing about bariatric surgery, thinking about it initially, and then actually going to that action phase of like, I'm ready to have bariatric surgery. You know, I just met a patient for the first time and she's been thinking about it for over 10 years. Right. And so that's normal. Most folks take years and years and years to kind of come to the decision of actually going through it. I think it's never too soon to start talking about it with people that you trust, whether it's someone you know who's had bariatric surgery, whether it's your primary care doctor, or it's whether you actually come to our office and just meet one of us, right?
Mm-hmm.
We're not tying you down to anything. You're not signing any contract when you meet us. It's just information, right? And there's always, and these seminars, right? That's part of their goal with these seminars is just like giving people information about this and kind of helping you along that process. Some people are going to move through it more quickly and some people are going to take some time. That's okay. But I would say engage as much as you can and learn as much as you can about things so that you can make the best decision for you. But it takes time. It's a big decision. You know, you're ready when you're ready. But I don't know. You said you think about this all. Sounds like it keeps you up at night.
So many things do, yeah. But because I was like, I think the first thing is because so many people are like, I want to lose weight, right? That's the first thing is you got to want to lose weight. You're like, I want to be later. I want that over there. And then I think you're ready when you say, I want to change to get there. Though desire to change is not the same as actually being successful in the change. And that's where a lot of people, I think, get held up is they're like, I want to change. I want to eat healthy food in small portions, but I just really struggle with setting myself up to succeed and then being consistent with my plan. And that's where I said, well, have we got some tools for you? Because if you want to lose weight and you want to make changes, we're going to do great. Like, we're going to be fine. Like, if you have that desire to make changes in your life to get better, we work with that. Like, you don't have to be perfect. You don't even have to be at certain standard or have tried a certain thing before you even come in. It's like, if you just want to change your life to to adapt some healthier behaviors, you're going to do great. And you're going to succeed and you're going to make success. And I've really kind of come, and on the backside of that is like, the only way that we're going to fail is if you quit. That's the only way we fail. So otherwise we're going to find a way to continue succeeding. And some ways are get more success and do it faster than others. But as long as you don't quit, we're going to be able to make progress.
Yeah. I mean, I think that's a great, I mean, I don't know if this is true for you. It's probably true for you to some degree, but like, this is the most refreshing part of our job. It's why I actually became a bariatric surgeon, is because our patients come to us ready for change. And that's not true for like pretty much any other specialty that you can go into in medicine. You know, like we both did a general surgery training.
Except for OB. OB was OB.
Maybe, yeah, just some, yeah.
But the rest of the time, it's like, I'm here because this sucks and this happened to me and I don't like it.
Exactly. Like I didn't come here today because I wanted my gallbladder out. I came here because I had to. So that's like such a refreshing thing to like see in all of our patients. And yes, it's a journey that we start together. And as long as we stick together and like continue on it together, that's like, we'll make progress. Right. Yeah. So, all right.
Well, any other questions?
I think that's everything I have on mine.
Patty, ready for closing statements? I'm just kidding, Patty.
She laughed. I'm just kidding.
Okay.
All
Great.
right. Well, yeah, I think this was fun.
Yeah. Thanks everyone for tuning in. Thanks for all the comments and questions. And yeah, we're here for you.
Yeah. Hopefully, I think this time I messed up my stream a little bit too, but next time we will be streaming on your Instagram and my Instagram and YouTube. And I think we're aiming for the 19th and
All right.
November. So
Very good.
yeah, we'll be talking about Thanksgiving and eating around Thanksgiving and
Oh yeah,
all
holiday
the stresses
time.
that the holidays bring.
I will say, like, this is the stretch. This is the hardest stretch for most people, is the Halloween to New Year's. So if you're
Indeed.
struggling at all out there, like, now is the time to reach out, because yeah, I mean, just having some extra biological tools, medications, surgeries, you know, like, it really helps. It really helps you kind of navigate these tough times. And so sometimes it's just for a short season, particularly medication wise. So
Yeah. It's a tough time no matter what.
Yes,
Even
it
if you're
is.
not trying to lose weight, you know.
Mm-hmm. No, those companies, they know what they're doing. They're multi-billion-dollar companies for a reason, because they know how to make food delicious and addictive. So, all right, everyone. Thank you much for tuning in. And yeah, we're always here. AvivaMD.com. Reach out.
Bye. Oh, and happy Halloween.
Happy Halloween.
Talk about Halloween.
There you go. Boo. Yeah.
Neither of us are dressed up. It's fine.